So we have a 66-year-old man that presents to the ED with complaints of substernal chest pain that worsens when he tries to shovel his driveway, but improves when he sits down and rests. What kind of medications should we start this man on to prevent future episodes? In this lecture, we will cover what are the main medications used in the prevention of angina, and what physiologic effects do these medications have on the cardiovascular system. Anti-anginal therapy refers to medications aimed at the prevention of future chest pain in a patient that has already had it before. The reason behind anginal episodes is very simple. An imbalance between myocardial oxygen supply and demand. The heart is working too hard and demands more oxygen than it is able to extract from the blood in the coronary arteries. We need to augment some of the factors that determine myocardial oxygen consumption to alleviate the angina. These are how much blood is in the chamber creating the wall tension, end diastolic volume over preload, what the heart is pumping against, afterload, how fast it is pumping, heart rate, and how much does that chamber want to contract independent of the volume, contractility. We are going to discuss the anti-anginal drugs with a table from your textbook. Let's begin with the nitrates. How do nitrates work? They cause venodilation that increases venous capacitance so that more blood hangs out in the veins instead of returning to the heart. This drops our preload or end diastolic volume. A drop in end diastolic volume means there will be less blood in the chamber, according to the law of Laplace. If we decrease the radius of the chamber, we decrease the wall tension and drop myocardial oxygen demand. Why does ejection time drop? We have less blood in the chamber. The heart doesn't need as much time to pump the blood out, so why does blood pressure drop? We decrease preload, so that means we decrease the amount of blood pumped into the aorta. This drops our blood pressure. This drop in blood pressure will also trigger the baroreceptor reflex because the stretch receptors in the carotid sinus and aortic arch will not be activated as much due to the drop in pressure. This leads to a sympathetic outflow response that will bind B1 receptors in the heart to increase heart rate and contractility. Okay, now let's move on to beta blockers. Heart-specific beta blockers antagonize B1 receptors on pacemaker cells and individual myocytes. Decreased intracellular CAMP from beta blockade significantly drops the rate at which the funny channels responsible for setting the heart rate open is why we drop the heart rate. Beta blockers also decrease the ability of cardiac cells to increase intracellular calcium. This significantly drops contractility and increases ejection time. Because it takes longer to pump blood out of the ventricle, the combination of a drop in heart rate and cardiac output significantly decreases the oxygen demand of the heart. The effect of beta blockers on end diastolic volume is still something that cardiologists are researching, so you don't have to worry about that, because if they don't know, they cannot test you on it. Now let's talk about using nitrates and beta blockers in combination. They are mainly used together because nitrates drop the blood pressure and subsequently trigger the baroreceptor reflex. Beta blockers are a great way to inhibit this reflex so that there is no effect or potentially even a slight drop in the heart rate, while also further decreasing myocardial oxygen demand. The reason for the decrease in heart rate when using combination therapy is that beta blockers have a greater effect on heart rate due to their ability to decrease the depolarization rate and conduction velocity of the SA and AV node. Remember that beta blockade decreases the amount of CAMP available that opens the channels responsible for intrinsic funny depolarizations in the pacemaker cells of the heart. and also decreases the opening of L-type calcium channels. Verapamil directly competes with calcium at these L-type calcium channels so that it gives a similar result to giving a beta blocker. We also decrease the contractility a very small amount. Because the beta blocker still decreases intracellular calcium levels, despite losing contractility from beta blockade, the ejection time is going to be the same because we decrease the amount of blood in the chamber by venodilating with a nitrate. Why are partial beta agonists such as pindolol and acebutolol contraindicated in angina? We are trying to decrease myocardial oxygen demand, not increase it. Pindolol and acebutolol are non-selective beta blockers that also have the ability to stimulate beta receptors as agonists. Giving your patient one of these drugs will increase beta adrenergic activity in the heart and could make their angina worse. Flash quiz. Which of the medications discussed increases both heart rate and contractility? The answer is nitrates. Remember that a drop in blood pressure will lead to a reflex response to help with circulation, which leads to an increased contractility and heart rate. In this video, we learned that the three therapeutic anti-anginal options are nitrates, beta blockers, and a combination of the two. While they all work to prevent future episodes of angina, they have a variety of physiological effects on the heart and blood circulation. Thanks for watching, and be sure to click thumbs up if you enjoyed this video. This is a relatively new drug, ranolazine, that acts by inhibiting late inward sodium currents. So what in the world is this late sodium current? For unknown reasons, only diseased hearts have this late inward sodium current that occurs in phase 2. That's right, some sodium channels remain open throughout phase 2 even though calcium is the predominant ion entering the cardiac myocyte. The more sodium influx leads to more sodium available for the sodium-calcium exchanger. This exchanger will pump out sodium and pump calcium in. Remember that this pump is bidirectional, and even though the diagram shows it only going one way, it changes direction based on ion concentration. This overall increase of intracellular calcium will stimulate myocytes to contract more at baseline, and this increases diastolic wall tension. Ranolazine was designed to selectively block these sodium channels that are not closing when they are supposed to. So this is a good drug to use in the cases of angina that is not responsive to other treatments.
Hey, this is Kevin Budashevsky, and this is Sacubitril. So I'm going to break the normal conventions here and start with a question. So what is one lab test you could order that's good at telling whether or not somebody is volume overloaded? To state it another way, this would be a very sensitive test for the diagnosis of congestive heart failure. Right, that would be BMP. BMP is released in response to ventricular dilation, and thus it's a great marker of volume overload. It's essentially your body's way of saying that you have too much fluid on board and you need to get rid of it, so it results in a compensatory vasodilation and diuresis. So if somebody is euvolemic or hypovolemic and thus has a normal BMP, they of course are not in CHF exacerbation. So what does this have to do with our video? Sacubitril is a drug that works by preventing the degradation of vasoactive peptides like BMP released from the ventricles and AMP released from the atria. It does this by preventing neprilysin, which breaks down the two. I'm not going to include the pathway here because it's simply not high yield enough for you to learn for step 1, even if you're going for a 270. But we will talk about both the mechanism of action and the side effects here because it's always important to know the negative effects of any drug you could be prescribing. In addition to preventing the degradation of AMP and BMP, which we want because it allows for vasodilation and diuresis, sacubitril also to a smaller degree prevents the degradation of angiotensin II. Now, as soon as I say this, alarm bells should be going off in your head. Why would preventing the degradation of angiotensin II be a terrible idea in a heart failure patient? Right, because CHF is marked by overactivation of the RAS system. Your heart is not pumping enough, and so your kidneys think that based on their lack of blood flow, your volume down and subsequently activate RAS. As you can imagine, preventing the breakdown of angiotensin II would worsen this. And so there are two things here that make this less of a big deal than it sounds like. First, the prevention of degradation of angiotensin II is not nearly as robust of an effect as the increase in AMP and BMP. Second, and more importantly, sacubitril is given in combination with valsartan, which is an angiotensin receptor blocker. Kind of a softball question here, but why would concurrent administration of an ARB negate the negative side effect of increased angiotensin II? Right, it's in the name. ARBs are angiotensin receptor blockers, so even though there's more Ang2, you wouldn't be seeing the effects of that. The sacubitril-valsartan combination is actually a major deal. It's been shown to both decrease the mortality and hospitalization in heart failure patients with reduced ejection fraction. And in fact, it's shown to be superior to ACE inhibitors in mortality reduction. So expect to see more of this in the upcoming years. All right, time for side effects. You can see hyperkalemia. I put this near the bottom and with a frowny face because it doesn't make intuitive sense to me, but it happens nevertheless. I personally could see why the addition of valsartan to sacubitril would increase potassium, but given that sacubitril actually increases angiotensin II and therefore aldosterone, I would have expected potassium to be low and not high. Unfortunately, it isn't entirely known whether we get a high rather than low potassium with sacubitril alone, so this side effect is just one that you have to memorize. If it does help you, you can remember that sacubitril is usually given with valsartan, and that tends to lead to hyperkalemia. So let's cover the side effects that make more intuitive sense. So what are some side effects that you would expect based on sabutril's ability to prevent the degradation of ANP and BMP, and thereby increase diuresis? Right, you would expect to see effects of overdiuresis, like hypotension and lightheadedness. What are some potential consequences of increasing angiotensin II? And before you answer, remember that you usually also give valsartan with this drug, so you need to think of effects that won't be directly explained by aldosterone. This is a tricky one, but I was going for cough induced by bradykinin. So you'll be blocking the angiotensin effects with the ARB, but since you have increased angiotensin II due to the sacubitril, you'll also have increased bradykinin, which can lead to a cough. Not surprisingly, you do not want to give these drugs with ACE inhibitors.
Hi guys, I'm Kevin Bodashevsky and this is lipid-lowering agents. So this is a particularly tough area of pharmacology because knowing these lipid-lowering agents function requires remembering and understanding some physiology behind lipid metabolism. So let's work through these drugs starting with cholesterol absorption. Alright, let's start with ezetimibe. Ezetimibe inhibits the absorption of cholesterol into the enterocytes by blocking cholesterol uptake receptor at the intestinal brush border. So how does the decreased absorption of cholesterol lead to a drop in LDL? Well, the liver needs to synthesize cholesterol to make lipoproteins. And since the body isn't getting LDL from the gut, the liver will increase LDL receptor expression, and thereby start pulling out LDL from the systemic circulation to make more lipoproteins. Ezetimibe has no effect on HDL or triglycerides. So the toxicities associated with this drug include diarrhea because cholesterol has an incredibly high osmotic gradient. Additionally, hepatitis is very rare, but because the drug is metabolized primarily by hepatocytes, it can injure hepatocytes and cause an elevation of LFTs. Okay, so this is a need-to-know fact. What is the rate-limiting enzyme of cholesterol synthesis? Right, that would be HMG-CoA reductase. If we inhibit cholesterol absorption, the body can still make it using this synthesis pathway. And what drugs inhibit this enzyme? Right, it's right on the screen. That would be statins, all ending in statin. So how do statins reduce LDL and triglycerides while increasing HDL? Well, LDL is low-density lipoprotein, and it's incredibly full of triglycerides as well as cholesterol. If you block the rate-limiting step in the hepatic synthesis of cholesterol, the hepatocytes are going to compensate by increasing the expression of LDL receptors. And just like we just saw, this is going to steal more LDL from the plasma. The end result is a drop in the circulating amount of LDL. The liver will also have to produce more HDL to take cholesterol and triglycerides out of the peripheral tissue and bring them back to the liver to make more LDL. What are two commonly tested side effects of statins? Right, that would be liver injury, in which you would see elevation of LFTs as well as myositis. The co-administration of what other class of drugs along with statins would increase the chance of myositis? Right, that would be fibrates. These side effects are likely to show up on your exam. Hepatic CYP enzymes metabolize statins, so it makes sense that metabolism of the drug can cause damage to hepatocytes, and that can lead to transaminitis, and particularly look for increased ALT. Alright, now let's move on to niacin. So niacin, or nicotinic acid, is a complex B3 vitamin, and it's converted to NAD or NADP. Niacin inhibits lipolysis via hormone-sensitive lipase in adipose tissue, and this decreases the liberation of free fatty acids from adipose tissue, which means less free fatty acids will be available to form triglycerides. In hepatocytes, niacin also inhibits the synthesis of fatty acids. Without fatty acids, the liver cannot make very low-density lipoprotein. Because most LDL is generated from VLDL, this inhibition of VLDL formation will also decrease LDL. Niacin increases HDL by inhibiting HDL reuptake at the liver. The side effects are rather unique, and you may have experienced them if you ever drank a 5-hour energy shot because it's loaded with niacin. So niacin induces prostaglandin synthesis. And elevated levels of prostaglandin dilate vessels and cause flushing, most notably in the face. A great way to inhibit flushing is to administer what medication? And to put this another way, what medication decreases prostaglandins? Right, that would be NSAIDs. Additionally, niacin can cause hyperglycemia. Alright, ready for another high-yield tie-in? This patient is suffering from what? You got it, gout. Niacin competes with uric acid for excretion at the pumps of the proximal convoluted tubular cells. If the patient's taking tons of niacin, the pumps of the PCT cells will now have to choose between pumping out niacin or the uric acid, and this is how niacin drives up the uric acid concentration. The increased levels of uric acid will now deposit in the synovial fluid of joints. So what would you see if you tapped this? Right, so if you stuck a needle into the joint and pulled out some fluid and looked at it under the microscope, you would expect to see negatively birefringent monosodium urate crystals. Alright, so next up is fibrates. Fibrates work to upregulate lipoprotein lipase as well as interact with the transcription factor PPAR-alpha. The upregulated LPL results in liberation of free fatty acids by breaking down triglycerides. And the activation of PPAR-alpha induces the synthesis of HDL. Fibrates also inhibit the reuptake of statins, leading to an increased risk for myopathy. Fibrates also inhibit cholesterol 7-alpha hydroxylase, which results in the increased formation of cholesterol gallstones. So next we have the very positively charged bile acid resins. Bile salts are in bile, and they're made in the liver from conjugation of amino acids with bile acids, such as cholic acid, made from cholesterol, which happens to be rather negatively charged. So bile acid resins target and bind to these cholesterol-derived acids, and that's why the roots of their name, if you look at them, resemble the name cholesterol, so cholestyramine, cholestipol, and cholesebolin. By giving a bile acid binding resin, what you're doing is inhibiting the bile acid reabsorption. So therefore, the bile acids will be eliminated in the feces along with the cholesterol. And so will all of the fat-soluble stuff, especially the fat-soluble vitamins. Can you guys remember what those are? Right, so the fat-soluble vitamins would be A, D, E, and K. And can you guys remind me what the vitamin K-dependent clotting factors are? Right, that would be proteins 2, 7, 9, and 10, as well as proteins C and S. By losing bile resins into the toilet, then the liver is going to have to make more. So as a result, the hepatocytes will use up all of the available cholesterol and then start expressing more LDL receptors to take up cholesterol from the circulation, and specifically take up LDL. Again, this should start looking really familiar. So this is how a bile acid resin can decrease LDL levels. The only drawback is that the induction of hepatocyte production of more bile acids also produces more triglycerides. So this is the only drug on this page that increases triglycerides, and so it's worth remembering. Note how there's only a slight increase in HDL levels. So what are some other effects of the bile acid resins? Well, you're making somebody eat an insoluble resin, and so it can cause constipation. And of course, as mentioned, it decreases the absorption of fat-soluble vitamins as well as everything that goes with it. Alright, so we also have the PCSK9 inhibitors, which are the monoclonal antibodies. These medications act to inhibit the actual LDL receptor degradation, and that means that effectively we have more LDL receptors that stay on the surface of hepatocytes, thereby removing more LDL from the blood. So like statins, these medications have been shown to decrease mortality in patients with coronary artery disease, and they have a profound LDL lowering effect, not surprisingly based on this mechanism of action. These medications can induce myalgias as an adverse effect, and they can also cause delirium, dementia, and other neurocognitive effects. Finally, fish oil and omega-3 can cause a slight increase in both LDL and HDL while decreasing triglycerides. The proposed mechanism of action is by decreasing free fatty acid delivery to the liver and decreasing activity of triglyceride synthesis enzymes. Alright, so let's review really quickly just the information on this table. So first up, statins. They work by inhibiting HMG-CoA reductase. And again, which two meds decrease mortality in coronary artery disease? Right, that would be the statins and the PCSK9 inhibitors. Use statins as first line for hyperlipidemia management. Next, the bile acid resins work by preventing the intestinal reabsorption of bile acids, and so therefore they can cause some GI issues. You can also see decreased absorption of your fat-soluble vitamins. Next up is ezetimibe, which prevents cholesterol absorption at the brush border and is also associated with some GI issues. Next, fibrates, which upregulate lipoprotein lipase, as well as activate PPAR-alpha to induce HDL synthesis. These medications work great to lower triglycerides, but they are associated with an increased risk of myopathy if they're used with statins, as well as cholesterol gallstones. Next, we have niacin, or vitamin B3. It works to inhibit lipolysis within adipose tissue and is associated with flushing, which you can prevent with NSAIDs. Adverse effects include hyperglycemia and hyperuricemia. The PCSK9 inhibitors inhibit LDL receptor breakdown and result in more LDL receptors being available for the uptake of LDL from the bloodstream. They're therefore associated with some neurocognitive defects such as myalgias, delirium, and dementia. Finally, fish oils and omega-3s do what to HDL and LDL? Well, it's on the screen. They increase LDL and HDL and they decrease triglycerides. Negative side effects of fish oil as well as omega-3s include nausea and, not surprisingly, a fish-like taste.